I'm going to play
Hi there, hope you're having a good meeting. Just to introduce myself, my name's Ben Pattinson from Karl Storz Endoscopy. Today I'd like to show you a new product which we've recently launched called the Telepack Plus. As you would expect, the new model has various improvements and new features. The first of those new improvements, which is a fully HD flexible video nasolaryngoscope. That flexible video scope will connect straight to Telepack Plus and will enable you to perform a routine nase endoscopy, as well as stroboscopy, and as well as enhanced imaging techniques using our S technologies and specifically Spectra modes. The Spectra modes are very similar to what is available from our competitors, namely iScan and narrowband imaging. The system will also connect to a lower cost video flexible nase endoscope, which is cost-wise very similar to a fibre optic scope. However, the features mentioned before are not available on that particular scope. And if needs be, there is a single-use endoscope which also connects to the system. The system will also attach to a standard camera head, which will facilitate connection to your existing flexible fibre optic scopes and rigid endoscopes that you already have in the clinic. The system is now utilising a touchscreen, so all of these icons for recording still images and controlling the light source can be touched from the screen. One of the other main enhancements or new features to the system is around the patient data recording system of the still images and the video files. This can still be stored internally, but in an encrypted format, and can be transferred now to encrypted USB sticks. The new system has been designed with networking in mind to connect to the hospital's electronic patient record or a simple FTP server where the data can be stored. The preference being a connection to the electronic patient record, obviously, and this is very easily achieved via something we call Sonara, and we have dedicated network integration specialists to help you with that, as every hospital, it would appear, is slightly different. I hope you found this video interesting. It's certainly been a new experience for me. If you do have any questions, then there are some QR codes to follow, which you can use to contact me directly via email or phone, or via Zoom and Teams.
Good morning, I'm Owen Pemberton, Commercial Director for DP Medical, and I'm here to discuss the collaboration between Zoran Technologies and DP Medical for the supply of CT products. We've partnered since 2018. DP Medical provide the direct sales and service support to customers within the UK and Ireland. Our primary focus has been on the XCAT and MiniCat, the intraoperative and office-based CT scanners. Zoran Technologies manufacture high-resolution CBCT scanners and are based in Ann Arbor, Michigan. Their HQ is situated close to the University of Michigan campus, and Zoran were founded in 2001 by two research scientists from the university. Their goal was clear. It was to develop a common sense, innovative technology that enabled physicians to treat patients more efficiently and effectively. Over the past 20 years, they have installed over 850 CT scanners globally. DP Medical are based in Chesington, Surrey, and supply products for ENT, gynecology, and dentistry, with representatives for service and sales. We have over 25 staff and a strong commitment to improving patient care and eliminating waste and inefficiency. We have registered the Zoran product range for purchase on both NHS and HSE frameworks, making the route to purchase even easier than ever before.
Since 2001, Zoran has been the pioneer and U.S. medical market leader in point-of-care cone beam CT. Zoran provides three-dimensional low-dose imaging with a workflow designed for simplicity and ease of use. Zoran's flagship product, the MiniCat, is an in-office point-of-care imaging solution for ENT and allergy physicians. Zoran's newest line of products, the XCAT suite of mobile compact CT systems, provides excellent medical imaging for the OR, ICU, and ER. Additionally, Zoran offers the VetCat, a fully mobile, easy-to-use CT scanner for veterinarians. The newest addition to Zoran's line of CT products, the XCAT IQ, is truly mobile with 0-degree turning, thereby maneuvering easily into tight spaces. Innovation does not stop at its physical features. The XCAT IQ delivers ultra-fast scan times with a low patient radiation dose and is specifically designed for the operating room, intensive care unit, and emergency room. Constantly evolving and progressing in the field of medical imaging, the emerging technologies in the medical CT community is an ever-changing landscape. With Zoran Connect, Zoran's cloud-based PAC system for remote viewing and backup, Zoran is uniquely situated to implement AI algorithms in the future that will help to provide high-level diagnostic assistant tools. Zoran is committed to making the complex simple, providing point-of-care imaging solutions at the place where patients need it, and thereby improving patient care overall. Visit zorantech.com. Since 2000,
we will now focus on the types of scanner available. Firstly, the office and outpatient device, the MiniCat. MiniCat is the flagship device for Zoran and is aimed at improving patient workflow by allowing patients to be seen and treated more quickly. This is achieved by providing points of care imaging of the temporal bone, sinuses, and skull base in the consultation room, with exposure to a relatively low dose of radiation. Since the pandemic began, we've seen an increased interest for the MiniCat as it reduces contact time with the patient and provides clear visualization of the sinuses, which cannot always be achieved via nasendoscopy. Most centers in the US are using the MiniCat in conjunction with their specialized allergy clinics. The scan time is relatively short, 20 seconds, and the time to rebuild a scan similar. So in under a minute, the scan image can be sent by remote reporting via the innovative Zoran Connect cloud software or analyzed on-site by the radiographer at the workstation provided. The scanner is enabled to send scan images via DICOM 3.0 and can also integrate with navigation equipment from most suppliers. The size of the MiniCat also makes it ideal for the outpatient setting, with it needing a space of 9 foot by 6 foot to accommodate the scanner and work terminal. Radiation protection is still required for the room, but this is fairly minimal due to the low dose emitted by the scanner. In many centers, the scanner is used for pediatric imaging protocols where nasendoscopy is not always permissible. And these are a couple of screenshots that we've taken for the NPR views. And just in this fourth segment here, that you can see the 3D reconstruction. The software is very easy to use and easy to manipulate the images.
Today, more than ever, patients want convenience, safety, and simplicity. With the MiniCat, you're able to deliver high-quality CT scans of the sinuses and ears at your point of care. Your patient sits comfortably in an upright chair, while an overhead arm makes a single rotation around the head. MiniCat scans have significantly less radiation than the traditional full-body scanners, and a typical scan only takes 20 seconds. Find out how the MiniCat can be a patient compliance game changer for your practice today.
So next up, we'll discuss the XCAT. So the XCAT is the intraoperative scanner and would be a a competitor to this traditional C-arm. Where the C-arms would be used for all types of CT, the XCAT is specialized for ENT protocols. So first of all, the device itself is truly mobile. It's got a small footprint. One person can move the scanner around from OR to OR. The images are superb, high quality, and with the XCAT XL, you can also now do soft tissue imaging, and there's some of the radiation information for that.
Today's cochlear implantation was challenging in that way that the cochlea showed an incomplete partition, type 3 specifically. So this is a surgical challenge because it's an anomaly. And as surgeons, we are very used to having landmarks to proceed in our procedure. So in this kind of cases, it's really helpful to have every kind of feedback or orientation. And that's why we really enjoyed the help of Zoran.
I think that Zoran is a very good machine because, you know, during the surgery, sometimes not easy for the surgeon to make sure the electrode is in correct position. During the surgery, we can do this CT scan. It's very, very helpful for surgeon. So we need this. I think it's a very good tool for surgeon.
The scanning was really fast, and the image quality within even less than 5 minutes was up to our expectations. We can really follow the detailed figures that we want to see on a CT scan.
You can do three-dimensional reconstruction. It's very good, very clear. I think it's very good for young doctors to learn something from this. Also for very experienced doctor, also we need this. Is very clear, very good.
So that's the XCAT in action. As well as the products that Zoran provide, they also have a superb backup. And since the pandemic began, they've been running regular webinars. And the next webinar would be on the 15th of April. These are free to attend, and registration can be done via the link just shown here. Please check out the Zoran Tech website as well, where you'll find a lot more further information. Pricing can be attained from DP Medical for the supply in the UK and Ireland. Please email any inquiries to our sales inbox. Thank you very much for your time, and I look forward to meeting some of you soon.
Bhaskar, do you want to introduce Panos for the next talk, please?
So very good afternoon to all of you. Thank you for joining back into the conference. Our next speaker is Mr. Panos Asimakopoulos. He's a very, very enthusiastic young head and neck surgeon who has recently joined our team. He completed his training 2 years ago. He did a fantastic head and neck fellowship in US at the Sloan Kettering Memorial. And he's come back and joined our team and is doing fantastic head and neck surgery. The topic he's going to talk to us today is on imaging in head and neck emergencies. Over to you, Panos. Thank you.
Panos has kindly pre-recorded this lecture.
Hello everyone, I'm Panos Asimakopoulos. I'm an ENT consultant in Aberdeen Royal Infirmary. I have a special interest in head and neck surgery, and I've been asked today to speak to you about head and neck emergencies imaging. I was thinking what's the best topic to cover here, and I couldn't think anything better than deep neck space infections. So I'll speak to you about some of the management issues around this topic, talking also about anatomical considerations and some of the surgical approaches that I find quite useful when I have imaging modalities available. Some of the basic principles of management of neck sepsis includes securing the airway, managing septic shock, dealing with the source of infection, and also treating neck. Airway management can be secured in different ways. Traditionally, using direct laryngoscopy and intubation, although there are problems with bleeding, abscess, perforating into the airway, that can make your airway very, very precarious. Awake tracheostomy under local anesthesia has been traditionally used as well when the airway was found to be quite difficult. Positional stridor on lying supine can be an issue, and also surgical landmarks can be very difficult to palpate when the anatomy is distorted by the infection process. More recently, awake fiber optic and nasal intubation or oral intubation has been used. Problem with this is that you need to have the right people at the right time available, at the right hospital as well. There are issues with this, such as secretion spooling, and the tongue and the pharynx could be collapsing backwards, but there are maneuvers to help you go around these issues. Sepsis management includes resuscitation using fluids, empirical, and then tailored antibiotics based on your CNS results. Most commonly, these infections have a polymicrobial etiology, usually strep, staph, and Bacteroides species are commonly found. Medical management of these patients is very important. Be aware of comorbidities such as diabetes, renal issues, and immunocompromised or immunosuppressed patients can be quite difficult to treat. These conditions can be exacerbated by the infection, but they can also make the infection more severe. And historically, over the last few years, the most helpful imaging modality is CT. However, CT has a major limitation. It cannot always differentiate between cellulitis and abscess. And quite often, as we all know, CTs overcall cellulitis as abscess. The most pathognomonic sign that has been shown to be very useful in these scenarios is the presence or absence of air. And in addition to the encapsulated hypodense heterogeneous lesions that are more central in abscess formations compared to cellulitis. So there are some controversies recently about managing these conditions and managing them conservatively versus early intervention surgically. There's not that much in adults. Most of the evidence has been coming from pediatrics about this controversial topic. The last paper I found in adults was more than 20 years ago from Spain that has shown 90% successful rate on a small cohort of 30 patients. However, almost 40% of these patients had cellulitis and did not have abscess. On the contrary, in pediatrics, there is now some evidence to suggest that patients over the age of 4 years old with abscesses less than 2.2 centimeters can be managed at least initially for 48 hours with intravenous antibiotics, and only if they don't respond, then you should be intervening surgically. Of course, you intervene surgically if there is rapid clinical deterioration or the child is very small and requires ICU admission. The systematic role of corticosteroids have been questioned recently. Corticosteroids can affect the immune system, and in that case could be causing problems with fighting infection, but at the same time they can reduce edema and improve airway issues that you might encounter. In a systematic review of 31 studies, 3 of the 4 studies on deep neck space infections showed positive outcomes with steroids. However, these are all cohort studies, and there's no RCTs to answer this question. So a little bit about anatomy. The spaces in the deep neck space, infections that are involved include spaces in the facial region, the buccal, the canine, the masticator spaces, and the parotid space, spaces in the suprahyoid and in the infrahyoid region, and also spaces spanning the entire neck, such as the retropharyngeal, the prevertebral, and the danger space. We're going to go through all of these shortly, most of them shortly. So let's start with the first case, a 52-year-old presenting with painful swelling around her chin. There's no intraoral or tongue edema, but she does have poor dental hygiene. So obviously this is a classical case of a submental abscess. Submental abscess anatomically is defined below the chin into and inferiorly, the inferior border is the hyoid. It's bounded medially by the anterior borders of the digastrics, and the deep border is the monohyoid. These abscesses are managed externally with a small incision between the hyoid and the mentum. Another case of a 45-year-old with painful swelling around the right mandible, diffuse tender erythematous right submandibular neck swelling, and suspicious dental abscesses. As you can see here, there is an obvious periapical lucency extending through the mandible inferiorly into the soft tissues of the submandibular space. And you can see this better here on the bone windows. You can see the cortical bone being breached on the inferior border of the mandible. You can see this better here on the axial imaging. This is the abscess involving the submandibular space. Bone window is very important because in the bone window you can actually see the cortical breach. So let's now look at an abscess, dental abscess that goes in the submandibular but also the masticator space. And you can just about start seeing it here, involving the upper surface of the mandible. You can see it just here, the cortical breach. And I just wanted to show you, it wasn't very obvious on the soft tissue windows, but on the bone windows, exactly the same slice here, you can very obviously see the cortical breach on the mandible. So very important to look at your bone windows. And you can see here on the coronal imaging. And these are your bone windows here, displaying very nicely the cortical breach. So the routes of spread from the lower third molar can lead to quite a lot of trouble, as you see here. They can lead to masticator space infections on either sides of the mandible. They can lead to the lateral pharyngeal space posterior medially, and lateral they can lead to the buccal space as well. Of course, the sublingual space and the submandibular space can also be affected. So always remember dental origin when looking at submandibular and sublingual masseter and buccal space abscesses. But is that always the case? How about a 72-year-old with right-hander neck swelling, not improving after 24 hours of IV antibiotics, developing sore throat, also dysphonia and trismus? Seen by the dentist, they excluded a dental origin. And here we are. This is your CT. She has significant involvement even to the glossotonsillar sulcus area, coming down into the submandibular space, the sublingual, and soon the submandibular space, as you'll be seeing soon here, with displacement of the submandibular gland medially and inferiorly. It's a big facial vein here. The most important thing here, however, is to see how the airway is becoming more compromised. Although there's no direct extension of abscess into the airway, she has significant supraglottic edema. So she was treated surgically, as you can see here. Please note that she was intubated nasally using a wave fiber optic because she did have significant airway issues. No stridor, but impeding airway compromise very, very soon. You can see here that she's having erythema in front of her neck within only a few hours. The approach is external transcervical approach, going below the angle of the mandible within a convenient skin crease. We've marked some marks here, the hyoid bone, and this is the anterior border of the SEM. The subplatysmal level plane is elevated. You can see the facial vein here being pushed laterally, and the minute we incised the platysma, we had a lot of pus out. The the facial vein was ligated and retracted caudally. A blunt dissection was made towards the direction of the submandibular gland, and a finger dissection released more pus. She did very well and had a corrugated drain that was removed a few days later. So the submandibular space, the superior boundary is the floor of mouth and the tongue, the inferior boundary is the hyoid. Anteriorly you have the mandible and the submental space, and posteriorly you have the parapharyngeal space, divided by the malohyoid into the sublingual and the submaxillary space. It's quite important when you look at the scan. If you have involvement of the sublingual space only, then that abscess can be managed intraorally. If you have involvement below the malohyoid muscle into the submaxillary space, or some people call it the true submandibular space, then that should be managed at least externally. So here's your malohyoid muscle here, and this is a true sublingual space abscess. This is your submandibular gland, and this can be very easily managed intraorally. These patients will have a tongue that is pushed, that is elevated, and the floor of mouth will appear indurated. The most common causes are, as mentioned earlier, the third lower molar tooth, but you can also have lithiasis and also an infected ranula into the floor of mouth. The intraoral approach is relatively straightforward. You incise the mucosa in the anterior floor of the mouth, parallel with the submandibular duct, blunt dissection along the course of the lingual nerve, being very careful because, as we all know, this runs into the floor of the mouth. And if the submandibular gland or space is also affected, then external approach, as mentioned earlier, should be attempted. The surgical approach to the submandibular space, as shown earlier, includes an external incision at least 2.5 centimeters below the mandible, raising your flaps, mobilizing your SMG, retracting your malohyoid if you have to anteriorly to preserve the lingual and the hypoglossal nerve, and getting blunt dissection. It's very important when you get your finger in there to go all the way up towards the pharynx and to the medial surface of the mandible. Ludwig's angina is something that our dental colleagues see quite a lot, although it has become less common these days because of the early use of antibiotics. It's an airway emergency. The airway should be managed by tracheostomy or wave fiber optic intubation. Early IV antibiotics should be commenced. It's rapidly spreading cellulitis without always having abscess formation. Drainage is indicated when you have suppurative infection or radiological evidence of fluid collection or air in the soft tissues. Intraoral and external drainage should be attempted. If it's the submandibular space is involved, then external approach should be attempted. If you have involvement above and below the monohyat muscle, then through and through drains into the oral cavity coming into the external neck should be performed. Now let's look at a patient who is 15 years old and presents with fever and gynophagia. Let's look at the axial CT. The most obvious abnormality here is a hypodense, it's a lesion with a hypodense center with peripheral ring enhancement and irregular borders. Obviously, this is a parapharyngeal abscess with a little bit of involvement in the retropharyngeal space laterally. You can see it here. Most of the involvement in the retropharyngeal space is light, but the true abscess is in the parapharyngeal space. The parapharyngeal space is an inverted pyramidal structure. The base is at the skull base, the apex is at the hyoid bone, the medial border is your buccal pharyngeal fascia, which is essentially your superior constrictor and your tonsil. Your lateral border is the ramus of the mandible, the medial pterygoid, and the parotid. Posteriorly, you have the carotid sheath, and anteriorly, you have the submandibular space. It's divided into the post-styloid and the pre-styloid, as divided by the defined by the tensor veli palatini and its fascia. The pre-styloid contains the imax, the internal maxillary artery, the inferior alveolar nerve, the lingual nerve, the auriculotemporal nerve, the deep lobe of the parotid, fat, and occasionally ectopic salivary gland tissue. The post-styloid space includes the internal jugular vein, the carotid artery, the sympathetic trunk, and also cranial nerves 9 to 12. Parapharyngeal space, usually infections in the parapharyngeal space usually stem from the tonsils, the pharynx, the teeth, salivary glands, the nose, and rarely from the mastoid or something known as basalt abscess. Communicates with parotid space, the retropharyngeal space, the submandibular space, the masticator space, and as mentioned earlier, contains the carotid space. The approaches to treat these, to drain these are predominantly external, but the transolar approach can be used in infections involving only the pre-styloid space, where an incision is made on the anterior tonsillar pillar, laterally to the tonsil, and the drainage pathway, can be performed relatively easily. However, any involvement onto the post-styloid space has to be done externally. And the approach is relatively similar to the submandibular space, but what's very important here is to be able to do a finger dissection posterior to the belly, the digastric, all the way up onto the tip of the styloid. So it's not just getting your finger into the mandible, as we said for the submandibular space, but actually get your finger all the way up the skull base into the styloid process. So let's look at now a 45-year-old with a history of depression and anxiety presented to the general medics with delirium. She had a CT scan of her head looking for sources of delirium and localizing imaging on the CT picked up a foreign body into the cricopharyngeus. This was thought to be a double picture hook that was dislodged in the upper margin of the cricopharyngeus and penetrating the posterior wall of the pharynx at the cervical esophagus at C4, C6 level. And as you can see here, she has a retropharyngeal pocket of air, and further down you can see fluid level, fluid collection. So the picture hook was removed successfully endoscopically. However, she had a large perforation, which was thought to be managed at the time conservatively because she was not septic. She was confused but not septic. An NG tube was inserted, but unfortunately this curled into the esophagus. The plan was to commence TPN, but unfortunately over the next 48 hours she developed a fever and became profoundly septic and more confused. So when in external, she had a CT scan to mainly look for extension to the chest, which thankfully she just about did not have. So she was managed with external approach. You can see the extent of the fluid collection, which was getting worse here. It was an external approach, and she did pretty well. The NG tube was now inserted successfully, and she was managed by an external corrugated drain, and she was packed with rebound gauge. The reason why her pharynx was not repaired because the mucosa was found to be very, very friable. This is a case of a 55-year-old gentleman who swallowed a dental plate, and unlike the previous case, he was not successfully endoscopically managed. So that meant that the foreign body that was stuck here, lodged between C7 and C8, was not removed, and he required an external approach. As you can see, his pharynx again was managed conservatively with a corrugated drain, and although he took a while to heal, he managed to do very well, and he eventually left the hospital with no long-term problems with his swallowing. So the retropharyngeal space anteriorly is bound by the pharyngeal constrictors, posteriorly by the alar space, superiorly at the skull base, inferiorly at the level of the second thoracic vertebra at the tracheal bifurcation. Laterally, you have the parapharyngeal spaces. The most useful screening tool for assessing retropharyngeal space infections is a lateral soft tissue neck X-ray, and traditionally people have been looking at comparing the width of the vertebra to the retropharyngeal space length, and third of the length of the vertebra of the RP space should be more or less correlating with 1/3 of the vertebral width at the level C2, C4. When you go to C4 downwards, the length of the retropharyngeal space should be corresponding to the width of the vertebral body on a 1:1 ratio. So anything more than that is considered a pathological and suspicious for retropharyngeal abscess. However, these values have been not really set in stone, and the best way to confirm this is to perform a CT. The other clue on the soft tissue neck X-ray is loss of cervical lordosis. The retropharyngeal space can be drained by the intraoral approach when you have a superiorly based abscess. That can be initially localized by aspiration and then incised using Bovie monopolar diathermy and performing blunt dissection. However, when you have inferior based lesions, those should be dealt with via the external approach. Similarly to the retropharyngeal, similarly to the parapharyngeal space approach, you should be doing a horizontal incision. Don't think hockey stick incision has any role these days. Horizontal incision and exposing the SCM, expose the carotid sheath, divide the mohyoid, ligate the middle thyroid vein if you have to, also divide and ligate the superior thyroid pedicle to gain access to the prevertebral space. Be very careful of the recurrent laryngeal nerve when you do this approach, especially on the right side. So let's look at a 65-year-old with fever, dysphagia, and swelling and pain. As you can see, this patient is intubated. There is a significant collection involving the parapharyngeal space, the submandibular space, going all the way down to the mediastinum, as you can see here. And these are the situations where you should be thinking that you'll not be able to drain this through the neck, despite having had attempts before. This patient required input from our cardiothoracic colleagues for drainage. So the danger space is a potential space between the retropharyngeal and vertebral space. It's more or less a continuation of the retropharyngeal space into the thorax. It extends below T4. Anything that extends below T4 involves thoracic pathology. External transvertical approach along the SCM can be performed, but as mentioned earlier, mediastinum involvement should encourage you to get a hold of your cardiothoracic colleagues. So in a nutshell, imaging is very important because it can help you recognize early these abscesses. Yes, sometimes it can overtreat and it can overcall, but CT axial imaging in particular has made a big difference for us to recognize and treat this early. If we don't, then the patient could lose their airway. Patients could have septic emboli, develop septic shock, develop IJV thrombosis, also known as Lanier syndrome, have horrible carotid ruptures, multiple cranial nerve palsies, and of course develop mediastinitis, which is a potentially lethal condition. I hope you found this useful, and we'll be delighted to answer any questions that you may have. Thank you very much for listening.
Panos, that's a fantastic lecture. Real emergencies, head and neck. I don't think we have any questions. That's pretty good, I think.
Panos, can I ask one question to Panos, please?
Yeah, please. Yeah.
Of course.
Panos, what imaging would you recommend for penetrating neck injuries that you suspect some vascular involvement?
So yeah, thank you for raising that. Definitely a CT angio in that case. Definitely
okay.
CT angio. I didn't cover this. That's another topic itself. I only have 25 minutes. But yeah, CT angio is very useful.
Okay.
To localize for two reasons. One is to localize the injury, but also to if you have available any embolization facilities, you could refer to for embolization if there's any vascular injury that could be done radiologically, but mainly to localize.
Okay. Thank you, Panos. Yeah.
No problem. Thank you. Sorry about the noise. Then I thought there was a bit of, it sounded a bit choppy. Maybe next time I'll display it live, but something might have happened in the video. Sorry about that.
No worries at all. That's fine.
There's one other question. What imaging would you recommend for parotid space infections? Same, CT? HRCT?
Yeah, so you can start with an ultrasound. I think it's a good screening modality because quite often acute parotitis and parotid abscesses can be quite similar. So your ultrasound not only will confirm the presence of, well, will give you clues about the presence of pus, but you can actually do an ultrasound guided aspiration to send a sample to microbiology so you can guide your initial management. So I would definitely start with an ultrasound, and then if the patient is not getting any better and you plan surgery, you can do a CT. I hope that answers your question.
Thank you, Panos. Yeah.
Brilliant. Okay. Next is my turn. Am I right?
Is Mr. J. Manikavasagam. Firstly, I would like to thank, he's the IT man for this entire conference. He's fantastic with all the IT skills. He is a consultant head and neck surgeon working at the Dundee Teaching Hospital in Scotland, Ninewells Hospital. He's an excellent head and neck surgeon. He's an excellent trainer. He's very committed to postgraduate education, and he runs a wonderful intercollegiate FRCS course for our ENT surgeons every year, sometimes twice a year. I don't know where he gets the energy from, but he does a fantastic job and a very good, excellent pass mark following the course attendees. So I would strongly recommend all the trainees who are sitting for the intercollegiate board to kindly use the opportunity and attend his intercollegiate course. He also runs regular head and neck conferences. He's a very active participant in ENT Masterclass. So you can listen to some of his lectures in the ENT Masterclass as well. So he will now be talking on the topic, the role of imaging in head and neck cancers. Over to you, Jay.
Thank you very much, Mr. Ram. Great. I will try and entertain you for next 30-35 minutes. I just included a little bit of a benign as well, and because of last minute dropout of one of the faculty due to the personal reason. Good. Head and neck cancer and imaging, and also management. It's not easy. It's always confusing, whether it is clinically or radiologically or in terms of treatment. But if we have a consensus, we can manage the patient successfully. That's why we have a multidisciplinary team for managing head and neck cancer patients. This is actually a beautiful Tay River in front of my house. This is taken in the spring. This picture gives you some information, same view, but in a different season with a different type of camera when there is active snow in Scotland. And this is a beautiful evening sunset. The reason I put all the three pictures, though it shows the same spot, you can pick out different things when you look at the images. Exactly the same principle. Why you ask for a CT, why do you do ultrasound, why do you do MRI or something in the PET scan. So in my talk, we're going to more focus on the head and neck cancer and imaging modalities and some learning points. Particularly, I want to take this talk with case-based discussions and more surgical pictures, because I'm not the radiologist. I don't want you to become a radiologist. The radiologists are doing their fantastic job. But as a surgeon, you need to know, or you need to interpret the radiology scans, and you have to apply that skills in terms of planning and managing this patient more effectively. That's the whole idea of this talk. So I will be introducing a lot of polls, which means you can answer the polls by clicking the button. Let's start this poll. Why do we need to organize cancer imaging for a cancer? Let's launch the poll. You can answer this. Then I will share the screen so that everyone can see what they are. I hope you can see the screen. Can you able to, yes, people are voting, that's very good. I'll wait for 20 seconds so that everyone answer. Almost half of them answered these questions. Wow, that's so fast. I'm glad you guys are very familiar with answering polls in the. So the question is, the answer is, okay, I'll close the poll and I'll share the results. These are the kind of results of the poll. So why are we doing the test for the cancer? First is a correlation of symptoms with the patient's condition. That's a very good answer. Staging of the cancer. That's the majority of people said that as well. So everyone is in agreement. When you want to stage the cancer, you have to ask for the scans. Planning the treatment, whether it is surgery or radiotherapy, almost 86% of them voted yes. And response to treatment, that's pretty much good as well. and recurrence detection after treatment, 78%. Actually, the answer is all of them we can assess by doing imaging. That's why we need it. But I'm very glad all of you voted more than kind of 80% except the first one. That's good. All right, so the answers are everything. You can detect the cancer early, stage the cancer, and also particularly the post-treatment, and also, but in some cases, interventional radiology is very useful in terms of managing complications, particularly head and neck cancer, either after surgery or after radiotherapy. This is clearly you can see.
I noticed the lump at the left-hand side, and then I went to the doctor.
How long's been there, the lump?
Not sure, but it was probably about October that I noticed it.
Is it growing faster, or?
I don't think so.
Is it affecting your breathing?
Affecting the breathing, yes.
In what way?
I feel I'm not getting enough breath in when I'm walking.
So clearly, there are two concerns here. There is some concerns about the airway, and it's a large thyroid lump. So why do you need to do imaging? Anyway, you're going to remove this tumor. You can see that it's nearly half a feet, 15 centimeter large thyroid lump. And the concerns are here. You can see on the top left-hand side, there's a fiber optic intubation of the trachea and the larynx. You can see anterior, posterior, kind of springing back. It's clearly, it's a sign of a tracheomalacia. So if you know these things, you can plan the operation very well, particularly in the post-op. Post-operatively, these large thyroid patients may develop tracheomalacia within 48 hours. So those patients are managed in a multidisciplinary team, particularly with the airway anesthetist and the intensive care unit for safe surgery. The next is the surgical planning. When you do the large surgery, you may have to use special devices like harmonic focus to make it faster, to keep the time in terms of finishing the list on time. And the most important thing is the vessels, because if it is a large tumor, it displaces the vessels, for example, carotids and the IJV. So if you know beforehand by looking at the scans, particularly with the help of the radiologist, it helps you to plan the operation very well. And also you can guide the trainees very well as well. And the last but not least for this case is about the trachea. We talked about that, tracheomalacia. You can also, during surgery, you can see how soft the trachea is. And that predicts whether this patient can be extubated in the theater or maybe electively could be extubated in the intensive care unit, or very rare cases, they may need a tracheostomy. But in my case, I never had anything in that extent. You can see in this slide, the learning points are tracheal compression. Retrosternal extension is another important point. You can remove most of the tumor from the neck or a thyroid lump from the neck. Some cases, you have to get cardiothoracic input to remove the tumor from the mediastinum. And the CT scan or ultrasound scan will give you some information about the neck nodes as well, because thyroid surgery is very different from squamous cell cancer. It's nice to know where the nodes are so that you don't miss the significant nodes that will show up when you're treating a thyroid cancer. And this is a large tumor or thyroid lump, which is actually trying to squeeze the trachea. So normally the trachea is a D-shaped. If you look at this picture, this is an intraoperative thyroidectomy picture. And this is actually what you see is the tip of the iceberg. If you even the simple chest X-ray, which clearly shows the large retrosternal extension going into the superior mediastinum. this patient underwent a thoracotomy or sternotomy to remove that large thyroid lump. Even if you look at this one, clearly it's squeezing the trachea all the way down to the superior mediastinum up to the arch of the aorta. If you look at this scan, it's not much tumor in the neck. It's everything is actually in the mediastinum. Let's come to the thyroid cancer perspective. So here, for particularly the thyroid cancer, what you really need to know whether the tumor is involving the esophagus, how much is trap muscle involvement, because that decides the staging, and the tracheal involvement, and particularly there is any calcifications in the ultrasound scan. If you look at this picture, there is a tumor there. There is a clear plane between the esophagus and the tumor there. So it means your dissection is going to be easy. But on this side, to the upper extent, where close to the cricoarytenoid joint, there is no clear plane. If you know that well before surgery, you can plan the operation very well, because you don't want to reveal any surprises, particularly the perforation of the esophagus and managing these cases in the last 2 hours of your operation theater, which is not really good. The mortality is very high. There is esophageal perforation for, particularly these patients are like very frail, 70s, 80s, and you have to anticipate these things. And better, it also enhances your counseling ability before the operation. Exactly, this is what we predicted well before. You can see I was just peeling the musculature, esophageal musculature, but leaving the mucosa intact. So I predicted this one with the help of the scan before. It was particularly useful in this cancer surgery. The next one is the tracheal involvement. You can see this tumor is actually involving the trachea and the cricoid cartilage. I have to shave this because of it is a thyroid cancer. The post-treatment radioiodine will be a good idea rather than doing radical surgery. And this is lymph nodes. You can see bluish, blackish lymph nodes in the papillary thyroid cancer. It was actually hidden on level 5. It is usually you can miss this one, in particular in the thyroid surgery, if you read the report or if you sit with the radiologist about the neck nodes, then it helps to remove the cancer in an effective manner. This is a picture, clearly shows. You can see this is tumor-free. This is a tumor is involving the tracheal lumen or thyroid cartilage, and also shows the neck nodes. So that is about the thyroid. So let's go to the parotid. So parotid cancer, or maybe a lateral temporal bone resection cancers, how much the scans are important for cancer surgery. Facial nerve, you can't really see the facial nerve during any of the scans, but MRI can give some information, or sometimes they may see the veins next to the facial nerve. That gives you some information. So, but what you see really is the character of the lump, the margins, and the neck nodes, and the involvement of the superficial and deep lobes and any neck nodes. These are the main features you can see in the parotid area. See, for example, this is external ear canal cancer. It may look small, but remember the ear canal is related to the parotid and the mastoid and the brain on the top, and the lower part is the neck nodes. So you need to have a lot of information before embarking on major operation. So for a parotid, learning points are, look at the margins of the lesion and also find out whether there's any deep lobe involvement, any neck nodes, or any intraparotid lymph nodes. To some extent, they can tell you more about neural involvement or mastoid involvement, if it is aggressive malignancy. This is a 82-year-old gentleman who presented with a lump in the 2 months. GP first organized, GP means a general practitioner, organized ultrasound scan. It showed a pleomorphic adenoma possible. So there was some delay in seeing the patient, but by the time 5 months for various reasons, till that actually the facial nerve was normal, skin was okay, skin and scalp, all the region fine. So what next? Shall we list the patient for operation? But we did organize MRI scan. I usually organize MRI for a parotid reason. The reason is it gives you better information than the ultrasound scan in terms of margins, in terms of any extra nodes, and in terms of involvement of the deep lobe. It helps me to plan the operation as well. So this one, radiologist clearly said the inferior margin looks dodgy, is irregular, and also is involving the deep lobe. It's closely related to the trunk of the facial nerve. So, and it was actually planned for surgical removal. The question was, we tried to establish a diagnosis before. In spite of that, there's no positive diagnostic. Then we proceeded with the operation. So in terms of surgical planning, we thought we have to remove the skin because by the time we see it was infiltrating the skin. So if you remove the tumor along with the skin, you need to sort out your reconstructions. Are you going to do a primary closure or free flap or local flap? One of the idea was a submental flap. It's a pedicle flap. You can just flip over to there. But if you have a tumor there, there is a likely our neck nodes going to be here. So you need to make sure there is no neck nodes here to use that flap. So that's where the scans are coming in handy. The next thing is the tumor is sitting right on the facial nerve, close to the ear canal, close to the mastoid, and you want to know where there is involvement of these structures. And the next important thing is facial nerve was intact. Are you going to find the facial trunk first, or are you planning any retrograde dissection? So this particular case, I planned the retrograde dissection, which helps to speed up my operation rather than digging in this area where you find the facial nerve trunk, but the tumor is also there. And the submental flap was used and the reconstruction was carried out after neck dissection. This particular case, I had to sacrifice a facial nerve, but I have anastomosed the remaining trunk with ansa cervicalis. So that's how we did the primary reconstruction. The patient did also have a radiotherapy after surgery. This is almost fourth case. This case is an adenocarcinoma of the parotid gland. It was previously treated by surgery and also radiotherapy, but you can see there is some recurrence. It does look like a superficial ulcer. If you go and remove it, that means you're doing a gross mistake. You really don't understand what you're doing. So this particular case, you need to use your radiographic eyes, a sheet in front of your eye. So what are the structures in the deep? For example, starting with the TMJ joint, you want to know whether there's any TMJ joint involved. And the next step is possibly the parapharyngeal space. And above it's connected to the foramen ovale, to the brain, then maxillary artery, zygomatic kind of bone, masseter muscles, and the neck nodes. And the lower end, you have neck nodes, IJV. So quite a few structures are involved in that area. That's what your thought process should be. So this patient had a lateral temporal bone resection. We started with a mastoid with the help of the otologist and trying to remove end block resection and trying to do the neck dissection by preserving IJV and the spinal accessory, and we're trying to come across the hypoglossal nerve, clearing the inferior bit, and coming to the posterior bit. Patient is undergoing mastoidectomy, a combined approach tympanoplasty to remove the end block removal of the ear canal. And in the front, we're trying to divide the zygoma, and we are approaching TMJ joint that has been disconnected. Underneath, you see the lingual nerve and also mandibular nerve, then the foraminal valley. So if you see, if you in the preoperative setup, if you see there is a foraminal valley was involved, it was going to the intracranial, that's one of the contraindication for the operation. So in this case, it was not involved. So that's why we this patient underwent radical surgery. And this is jugular bulb and combined approach temporoplasty pictures. So we are trying to remove end block of this tumor. And that's the maxillary artery, which comes under view. So this is a division of the masseter. This is a beautiful anatomy. This is what you have to look through the eyes of the scans. This is the foraminal valley. There is a connection to the imagery veins. So we use the flow seal there. This is actually middle ear, and the tegmen, and the sigmoid sinus, and the jugular bulb, and spinal accessory, internal carotid artery, then hypoglossal nerve, and the lingual artery. This is mandible. So this is a final specimen, and the reconstruction. Use a temporalis flap in this case. Sometimes a facial attack can be used to lift the face, and the free flap is the final reconstructive method for this patient. So this is, we discussed thyroid, parotid. Now let's go to the submandibular gland. The picture shows the side profile. There is a lump in the level 2, which is probably 5 centimeters in size, and the good mouth opening. The reason I put there is no trismus for this patient. So it was treated by multiple course of antibiotics by local doctor. Not much improvement. So when the patient come to the hospital, we arranged some bloods and CT scans, which actually showed there is a rim-enhancing lump there. But in addition, it also showed multiple globular neck nodes. So the diagnosis actually initially from infection just straight away changed into something different. The white cell count is slightly higher. CRP is not that high, it's just 41. But the lymphocytes and neutrophils are higher too. So the CT scan clearly put some direction. It doesn't look like kind of infection. We are dealing something like malignant. It's a CLL because there was nodes in the neck and the hilum and the mediastinum. So instead of patient going for IND, the patient was going for a co-biopsy of the neck or lymph node biopsy, something. But this patient, we did a co-biopsy that was more than enough to give a diagnostic material. So this is another scan. Now we are moving on to oropharynx and the hypopharynx region. So this particular scan shows there is a coin-shaped lesion in the posterior pharyngeal wall. But when you look at the different image, you may consider that actually it's a tongue lesion sitting in the posterior pharyngeal wall. So the reason I put this one, there is always a limitation of the scans. So it has to be correlated with the clinical finding. Sometimes when the patient lies down, the tongue falls back. The lesion sits and touches the posterior pharyngeal wall. That picks up in the scan. It means it just, it overstaged the tumor. So always looking at the clinical picture is important. So this patient actually, HPV tumor in the posterior pharyngeal wall was resected by transoral laser surgery. And we are managing this patient without chemoradiotherapy. Moving on to the nasopharyngeal cancer. Nasopharyngeal cancer is uncommon here, but still we do see patients. You can see there's a small lesion, or it's pretty obvious lesion with a with kind of proliferative growth. You can clearly see the eustachian tube orifice on both patients. So let's ask some questions. What are the symptoms of the nasopharyngeal cancer? And let's Let's answer. The first question is nasopharyngeal cancer symptoms and signs. You can choose more than one. It's a multiple choice right answers. So unilateral epistaxis, neck lump, and then you can vote now. Unilateral nasal blockage, mass in the nasopharynx, unilateral sensorineural hearing loss, headache, and also the next question is preferred radiological investigation. In the preferred radiological investigations, we have CT, MRI, CT and MRI, and PET-CT. So it's a two questions. I will give a bit more time so that everyone can vote. Good. I'll end the poll and I'll share the results. So majority of them said unilateral epistaxis and neck lump. That's the correct answer. Unilateral nasal blockage, it's also a right answer. Many of you voted. Mass in the nasopharynx, that's correct. Unilateral sensorineural hearing loss, that was a kind of trick question actually, a trick answer. Actually, it is unilateral conductive hearing loss. You do get the eustachian tube blockage, then glue ear. So that is the wrong answer, but it is a trick question. Headache, yes, is one of the presenting symptoms because of the intracranial metastasis. Preferred radiological investigations, many of you said CT and MRI both together. That's impressive. I think that's what we might be doing in most of the centers in the UK. And PET-CT is also a reasonable investigation for the nasopharyngeal tumor. Right. So coming to the nasopharynx staging, the staging scans are very important. Particularly, there is a recent change in the classification because the tumor size is different, and nodal size is different. It's a 6 centimeter is a benchmark, and also a cricoid cartilage is the line of division. This is a small T1 cancer involving the nasopharynx. It's less than 2 centimeter in size. This is larger, relatively larger, involving the lateral pterygoid and the right prevertebral muscles into T2. And this is a T3 tumor because it's involving lateral pterygoid, not the medial pterygoid alone. So, and the T4, it's involving the intracranial involvement. The neck nodes, it's common to have retropharyngeal lymph nodes as well. And there's a bilateral neck nodes is known for nasopharyngeal tumor because of the midline structures. More or less, a nasopharyngeal tumor and also HPV tumor, the diagnostic staging is more or less similar. So when we asked about this investigation for nasopharyngeal cancer, in my unit, CT and MRI we do both. And some centers, they do a PET-CT as well. MRI is useful, particularly if you do it in different sections. It gives you more information about the parapharyngeal tumor, sinus invasion, and the middle ear effusions, neck nodes, tumor extent, particularly perineural spread and intracranial extension. CT is useful because of the radiotherapy planning, and some centers, PET-CT is being used as well. So next is a larynx cancer. For a T1 small cancers, generally it's not necessary, but increasingly we do it because of the staging purpose and also find out the lung primary cancer. But certainly in these cases, I would want to have a CT scan, but this one is a superficial lesion, all T1 lesions. But this one, relatively a large lesion, and this case you want to know whether there is any paraglottic space involvement, because that takes the staging to T3 straight away. And in this case, there's no paraglottic space involvement, so I have done this by transfer laser surgery. You can see I'm palpating the lesion, but I knew well before as well as it is a bulky T2 lesion, but there's no.
I've had to date, removing the cancer from my voice box.
So that's good. So this particular area, you can see there's a horseshoe-shaped tumor very close to thyroid cartilage, but there's no breach, but it is involving the other side as well. This sort of tumors, it's T3, and definitely we will need a CT scan to rule out anything. This is T4, very large tumor, or it can be a small tumor, still it can be T4. But this particular tumors, as Panos mentioned, you are concerned about airway emergencies in this case. Flexible endoscopy will give you only end-on view, but the underlying extents and can be best illustrated by the scans. Next is a oral cancer. How much information do you want to give to the radiologist? The most important question. And the best answer is give as much as information, particularly previous operations related to the head and neck. Because if you see this one, there is actually a radial forearm flap sitting on the floor of the mouth, and it was reconstructed before for a cancer in the floor of the mouth. This is a new lesion on the tongue. And the second question is, can you do biopsy before the imaging? And the previous answer was actually no. Because if you do biopsy, it just upstages the tumor from the radiologically because of inflammatory reaction. Increasingly, nowadays, we do outpatient intervention biopsy, which is a smaller 2 millimeter biopsy. I don't think that will make a huge difference in terms of staging, as long as you mention that in the in your request. So oropharynx, CT is also one of the investigation tool, and also some centers prefer MRI scan for various reasons. And this is a HPV tumor. The tonsil cancer, it can be ulcerative or smooth or exfoliative. Usually present with multiple metastatic neck nodes and cystic metastasis. And the next is unknown primary. I'm not going to talk a bit more about this one. You will have more information with Professor Asi's talk. So let's talk the role. This is a patient present with a neck lump, 2 months duration, pharynx and larynx involvement. What would you do? What is the most likely investigation? Let's ask the poll. Let's see what you can answer the poll. So he's 50 years old and he's got a neck lump, 2 months, pharynx and larynx, it's normal. What is your next likely investigation? People are voting. Because of the time, I'm just, yeah, okay. So many of you voted ultrasound guided FNA, which is actually a gold standard investigation. And also, they might be asked over the first radiological investigations. Certainly, you will do further scans like either CT or MRI scan, or may end up a PET CT as well. I think and the first investigation is a freehand FNA, which you are comfortable. Other option, if you have a If you have the facility, ultrasound FNA is the gold standard because ultrasound adds more information, and the FNA with ultrasound is generally 10 to 20% higher hit rate when compared to freehand FNA. And also it gives you more information whether the lump is a cystic or solid. So this is actually a tonsil primary with a metastatic neck node, which was not seen on the clinical examination, but it picked up by the MRI scan. So for unknown primary, the guidelines is first is FNA is negative, ultrasound guided FNA. Then go for imaging, either MRI or CT. If you find the primary, go for image directed biopsy. If you don't find the primary, they need to have a PET CT. If even in the PET CT there is no tumor found, the minimum operation is bilateral tonsillectomy and endoscopy and tongue-based mucosectomy is a reasonable investigation. So the oropharyngeal staging is slightly different. We will skip this talk, but I will, because the staging, the main point is there's a new staging for HPV 16 in TNM 8, and the sizes of the node is different. It's a 6 centimeter, unlike the other one. There is no A, B, C staging. So that's the point I want to highlight. And this HPV tumors, tongue base and the musculature takes it to T4. So this is, I'm just coming to the end of the talk. The last but not least is the surgical planning. So this is the last poll. This is a patient. You can see he had a PET CT. He's a HPV tumor. He had a chemoradiotherapy. That's the picture after chemoradiotherapy. The PET CT showed a hard spot in that area, he needs operation. So why do we need to do scans for this patient? And that's the question I want to ask. He's 56. He had a HPV tumor. He was treated by chemotherapy and radiotherapy. Even after 3 months, he has got a sizable neck lump. This is what we were discussing before, assessing the treatment response. Okay, that's pretty good. People answered it. Yes. So this particular case, all the 3 answers are correct, actually. We need to rule out whether there is any primary disease. The primary disease was from the tonsil. If you have a persistent disease in the tonsil, you have to address that as well after chemoradiotherapy. Second is assessment of blood vessels planning surgery. Yes, particularly this large patients after a large tumor, particularly after chemoradiotherapy, the neck dissection is challenging. So you would want to know the major vessels and also any carotid involvement of the neck nodes, which you need to get help from the vascular surgeon. And the last but not least is disease response from the patient. So I think it wasn't any trick question here. So I was particularly interested in the carotid. As you see, the carotid was gently dissected, and I knew that IJV was involved. So I have tied IJV on the top, on the bottom. I did not spend much time in dissecting around it. I knew that it's really stuck there. So it helped me to save another 15-20 minutes of time. And the next thing was the tumor was sitting on the paravertebral muscles. I had to resect it, and the sternocleidomastoid was stuck in that area. So I have to resect part of the sternocleidomastoid. So essentially, this patient had a radical neck dissection, and the carotid was preserved. So in this case, even though I kept the vascular surgeon on the backup for this case. So This is Beethoven. He said, to play a wrong note is insignificant, but to play without passion is inexcusable. And that's a really nice quote. So from my point of view, if you manage the cancer patients without scans, you're not excused. Okay, I think that's the end of my slide. So to summarize, it is key. Imaging is a key for cancer management. It helps you to plan your surgery, and you can assess the treatment response. The most important thing is you need to have a collaborative approach with the radiologist, not a competitive approach with the radiologist. I hate doing ultrasound guided FNA. I don't want to do that. But there are some centers they do that. And be sensible with the investigations. And there is, if you are not sure, you could ask the radiologist what investigation they want, and make sure that is patient-centered investigations, not institution-centered investigations or money-centered investigation. Thank you. That's the end of my talk.
Thank you, Jay. That was an excellent talk. Even for a non-head and neck surgeon like me, I was able to understand so beautifully. Beautiful dissection. I loved watching every slide. Thank you for that. There is one question. Are you able to see the question, Jay?
Oh, that's yeah, that's right. Yep. How to roll Simon? How to distinguish neck nodes from the surrounding structures in the neck on the MRI? Also, what are the features of the bronchial cyst that distinguish it from the enlarged lymph node? That's a tricky question, to be honest. There's no straight answer for that. How do you distinguish the lymph nodes from the surrounding structures? The lymph nodes, especially cancer lymph nodes, enhance with the contrast, and also the size of the lymph nodes, particularly the location of the lymph nodes, will give you some guidance. And the best thing is, you don't need to identify the lymph node. Ask your radiologist; they will tell you this is the lymph node. That's what I do. Yeah, that's a very honest answer. The second thing is, what are the features of the bronchial cyst that distinguish it from the enlarged lymph node? The bronchial cyst is a smooth-walled large cyst. It is, again, one of the differential diagnoses, metastatic cystic lymph node. They can't say for sure. It is a diagnosis of suspicion, and you have to treat this patient as a cystic neck node rather than bronchial cyst. Bronchial cyst is a diagnosis of elimination. I think that answers your question. Someone said excellent talk. That's fine. Thank you. For early stage cancers of the tongue, what imaging would you recommend, MRI or CT? I personally prefer MRI scan. Some centers prefer CT scan because a CT scan is quick and they can do only one scan, and they can add the CT chest as well. So that saves the time and money. But some cases, if they have a dental artifact, the CT may not give you enough information. They will end up have a MRI scan. Sujan, looking at the patient's cost factors, would you prefer CT PET or MRI for the neck, larynx? Radiologists say good 3 Tesla MRI and also distinguish bone invasion. What do you say? Coming to the cost factors, for the larynx, I only prefer a CT neck and chest. That's more than enough. We don't do a CT PET routinely for laryngeal cancers. That's waste of money. But it can be done when you're planning for a salvage laryngectomy, especially if you want to avoid neck dissection. Kim will talk about that. If it is CT PET negative, that gives you more information. That's good. Someone said excellent. Thank you very much. And there's one more. For a carcinoma of unknown primary, why do you both CT and MRI? Wouldn't be more beneficial to PET CT and then targeted panendoscopy and biopsy? That is actually a good thought. PET CT normally takes in my center a bit longer, and also it's 4 hours. My mom had it. I was sitting with her. It's not a pleasant one to have it. And CT normally takes 3 minutes, and MRI takes 40 minutes. It's quicker. And the CT and MRI could potentially show your primary straight away. So if that fails, definitely you need a CT scan. I think that's it. Yep. Okay. Thank you. I think that's a coffee break for us, isn't it? Yep.
Yeah.
And we'll be back at what time, Ram? We're back.
Clock at the moment. The next lecture is supposed to be at 3:30.
3:30. So we'll be back at 3:20.
Sure.
There's a one sponsor video I have to present. Then yeah. So 3:20 we'll be back. 20 minutes break. Yeah. Thank you.
Thanks, Jay. That's good. Cheers.